These slides.
If there are no questions, I can start with a question. Okay. So, Dr. Rosella, you mentioned when talking about explainability, you mentioned black boxes and simple models, and you noted how there were, I don't know if there were clinicians, maybe the technical folk have better understanding, but maybe it was clinicians who were not able to interpret simple linear models. So how do you think education needs to evolve to help the physician of tomorrow to be successful in an AI augmented future? You did mention that there's a class that the University of Toronto's medical students take. So what is the exact curriculum to make sure that they're learning it the right way? And also for you, Dr. Bhat, you deal with clinical fellows in hepatology. How do you ensure that they know how to use these models and interpret what the results are?
Yeah, maybe I'll kick off just to say that I actually think there's a false sense of security when you see a more simple model that sort of you understand what's going on mathematically or the complexity under there. And so just because we're getting more complex with these models, it doesn't mean that, it means that we have to actually have practices that make us trust what's happening. So the more important thing, what I would want any clinician to know is to make sure that that model has undergone the most rigorous gold standard processes with model development and validation, that there was transparency in how the model was developed. We use technology every day,
right,
and we trust that it works. Well, how do we do that? It's not us going in and understanding how all the things work. There's trust around it, and that goes with rigorous practices. And so that's the piece where I think it's about being a critical user and understanding whether or not those rigorous practices have been followed and have the gold standard processes have been followed. And it's not that different from what clinicians do already when they assess quality of evidence that they use for clinical decision making, but there's just different standards.
Yeah, so in our program, we have transplant hepatology fellows or transplant fellows from all over the world who come to gain clinical expertise. And I think what a lot of them now are trying to acquire is some education and knowledge in artificial intelligence, like tools of artificial intelligence. But certainly they all have that background in evidence-based medicine and epidemiology that I think is, it's important to keep that framework to then evaluate prospectively how well an AI tool will actually work in practice. Now, in terms of trust, I would say, as a clinician, I mentioned earlier, the ranked features, SHAP analysis is pretty important in my mind to, for me to gain trust in a model's output. But you are right that there are certain linear models, like say the MEL sodium is a score I use every day, and I actually don't, I may not necessarily know, okay, why the MEL sodium is as high in one person versus another. But, after some years of experience, you can kind of, the reality, however, is that you can kind of guess. Like I can now, look at a patient's blood results, which is just 4 variables.
Yeah.
And I can just say, okay, this patient is likely at a MELD of 28, and I will be right, within plus or minus 2.
Yeah.
So it makes it much easier to trust that, simple score. But I think it depends on how simple the model is, as opposed to, how complex it becomes. And with the complexity of the model, especially if it's going to make life and death decisions, I think we will need to know why it's coming to a certain prediction. We can't keep it black box because I think there has to be some degree of openness to that decision that needs to be conveyed to physicians, particularly I think people who are not as familiar with technology or not as open to AI. There's a lot of skepticism in the healthcare community in general, I would say, particularly in those who are a bit more senior. There's a lot of skepticism. So that's the reality. I can tell you, even at University Health Network, where people are very forward thinking, there's a lot of skepticism. So you have to convince, in the end, the computer scientist or, AI expert will have to convince those physicians that their model is giving accurate predictions, and then why are those predictions being made is also a very critical part of that trust.
Right. I just have one more question, actually, before I give you the mic. I actually, Dr. Mamatha Bhat, I wanted to follow up on the SHAP values and like the analysis that you've done, and how reassuring it was that it was like usually the top four or five were actually components of the MELD score.
Yeah.
Now, you worked on models that have really good performance, better than clinicians, but has that improved did you truly feel like, and you sort of touched on it before, do you feel like it's really improved your like clinical nonlinear heuristics in prediction? Like, is it like a gut feeling now, like you're saying, like after looking at the model results and like working with these models, that your own sense of prediction is better, and it's, do you think that's
so to be honest, like right now those models are not implemented except for one, so I can't tell you about those other models as yet. There's just one that, as I mentioned, we ran into some issues with. So it was this transformer model for post-transplant outcome prediction. And a part of the issue was that we were looking for a prediction of outcome that may not have occurred in many patients, in most patients. So that was one issue. We were looking at survival, and I think now we are changing that outcome of interest to events as opposed to survival compromised by events. So that's one thing. So now we've refined that model. We are refining that model for further implementation. The other thing was we realized that also this transformer model was probably a bit computationally heavy, like given the number of variables that were being considered and fed into our dashboard. So that was another thing. So we decided to simplify the model to reduce it to, say, 13 clinical variables of interest as opposed to 100 longitudinal changes, et cetera. So I think in terms of implementation, it's still a work in progress. So maybe I'll come back in a few years and I can talk to you about the results of implementation.
You have Rosella
but
right
I think,
here for implementation.
What's that?
You have her right here about deployment.
Yeah.
Go ahead, sir.
First off, thank you both for the wonderful talks. So I want to dig a little more deeply into the interpretability questions or explainability questions that sort of you were just exploring a moment ago, because I'm curious about your perspective on the notion that as the models that we work with grow in capacity and are able to make more complex decisions, that there is a risk that the ways that we ask them to explain things might diverge from how they're actually making decisions, or the sort of false sense of explainability where, if you ask a large language model to explain why it made a decision, it's not clear if that explanation it gives you is actually mechanistically or statistically related to the actual answer it gave you. And I think a related risk that I'll give an example as well, just to sort of ground this discussion, is that we know for a fact that certain ways that we think about medicine, ways that we have been trained to do medicine, and the ways that medical science has developed are biased towards certain populations and certain groups in certain areas. And so if we ask a model to explain its decision about predicting something, and one model gives us an explanation that doesn't make sense, and another model gives us an explanation that does make sense, but it specifically makes sense in line with the potential medical science that might be biased towards certain groups or things like that, like, does that induce risks of actually having this appropriate quest for understanding interpretability also have impacts on things like model performance, generalizability, and disparities and things of this nature?
Yeah, it's a very good, complex question, and it's, we could talk a lot about explainability, but one of the questions I always ask is like, great, you hear I'm reassured by my shot. Well, what happens if something comes up that you're not reassured? Does that mean it's wrong? Or does that mean it's just not aligning to your perspectives, which may be biased, or there might be something that we've uncovered that we need to learn, right? So I think we're in very early days with the explainability and interpretability methods. That's why I think we need to be pushing towards, explainability needs to be there, interpretability, we need to look at it and talk about it and discuss it, but we really need standard processes of model development and best practices that we feel, yes, that was done with the best adherence to what we consider best practices to be able to trust what's going on. But we're very early days, I would say, on explainable methods. I think we've seen some at this conference being presented. I think it's getting a lot better. But you're absolutely right. Like just because you can see it, just because you're telling me what's happening in the model, it still doesn't solve the underlying problem necessarily, especially if they're conforming to biases that already exist in the system.
Yeah, and I think you alluded to this, like say in our patient population, so transplant patients are a very special group of patients, right? So we will not be able to use a model that's been trained on a general medical patient population in a transplant patient setting. So what we are doing is actually reaching out, and I did my training at Mayo Clinic, so I have good collaborators at Mayo Clinic, for example, collaborators in Singapore and India, where we are looking to say assess model validation in those settings, and also understand, because like say even if the model works in those settings, say the actual reasons for that prediction may be quite different in those different patient populations. So the patient population at Mayo Clinic is likely to be different from the patient population at UHN. But nonetheless, we would at least be examining the external validity of these models in those different patient settings.
Yes, sir.
Thanks for the lovely talk. So my question was particularly about when we are selecting the patient who are eligible for liver transplant. So I was thinking on a population level, we see that there is a difference in the model compared to, like, I forget the name, the basic model, which is NLM model, which use only 4 variables, and then you train machine learning algorithm. But on a patient level, let's say I have a patient A, which scored really high on the very simple model, but when you train it in a machine learning model, that same patient now is on a very lower category.
Yes.
So there's a very big differential. So how do we explain that? Like on a population level, we might see a lot of difference,
Yes.
but on a patient level, they might be all over the place. So how do we look from patient specific if those number changes a lot?
Yeah, so we are looking at the reclassification of patients, and based on our simulations so far, we are seeing that we wouldn't anticipate an increased number of deaths, but rather a decreased number of deaths with our model as compared to the standard of care. The reason is because there are many patients who may be over-advantaged at this time, unnecessarily advantaged, whereas they could wait a bit longer. There are others who can't wait. And so when we look at our simulations of, say, liver organ allocation, we do see that we would overall serve the population much better with our model as compared to, say, the standard. But you are right that there are some patients who are currently over-advantaged as compared to those disadvantaged subgroups, and they will be sent to a lower category or a lower ranking, yes, but they would not be inordinately disadvantaged in terms of risk of passing away on the wait list.
Thank you.
Yeah.
I have a sort of follow-up question to that, actually. Because from my experience and where I've done training, I've seen in many like big transplant centers, certain transplant centers are very aggressive with how they choose their patient. Like it could be a very sick patient, but hospital B.
So candidacy, you're referring to candidacy, right?
Yeah, candidacy. And so, how does that kind of bias go into your modeling and your decision?
It doesn't actually. It doesn't go into the
at
model.
all.
So that's a whole other question.
Okay.
Which is, number one, there can be equity issues in terms of even the referral of patients for transplant.
Right. Yeah.
So particularly in the US, there are going to be inequities around who gets referred for a transplant, number one. And then once they are assessed by the transplant program, they get discussed at what we call liver listing committee meeting. So we do that on a weekly basis. So all transplant programs will have a weekly liver transplant listing meeting where we have hepatologists, surgeons, representatives from psychiatry, anesthesia, social work. In the US, there will be a financial person also, so a financial officer. So there will be different members of the committee that then try to make the most objective decision. So one person will present the case, and then everyone listens, and then basically they come to a consensus decision. So it can be straightforward for many people, but it may not be as straightforward for many as well. The reality is that patients have become more and more complex. So even in my so I started practicing as a hepatologist 9 years ago, and I can tell you that like even 9 years ago, we were not dealing with the complexity of patients that we deal with now. So many people will come in, they have a history of having had breast cancer 10 years ago, or a melanoma 10 years ago, or maybe they had a heart attack 5 years ago. 30 years ago, those people would not have survived, right? They wouldn't have even been referred to me for liver transplant evaluation. Like they would have not made it through that cardiac, event or that cancer event. The reality is that medicine has progressed so much in different ways, such that we are being referred more and more complex patients, like long-standing diabetes and so many things. So we don't necessarily even have the data to tell us like whether it's a reasonable decision to transplant one patient versus the other. So I think it's such a complex decision, and we try our best with our numbers of years of experience, like as a group, we're like 15, tend to be 12 to 15 people, and we try to make a best guess, in certain very complex cases, right? For the most part, I mean, it will be straightforward, but I can tell you that the complexity is tremendously increased. Now that we've entered this era of like more MASH, like fatty liver disease, and alcoholic liver disease. It used to be that hepatitis C was like the dominant, and it was a bit more straightforward actually at that time. But now, given that that's cured, now we're entering this more complex era with multiple comorbidities going into transplant. So it's become very complicated. So I'd say, and that's probably the case in all of medicine, like any field you practice in. Like I get referred patients who have, a history of interstitial lung disease, and then they're on some, one of those new agents. I've forgotten like which one, some Vetinib or this one that, Inib agent, right? So, and then they actually have reasonable pulmonary function. So then they come in, and then we say, okay, well, I guess you could make it through a transplant. Transplant is a big surgery, like a 6-hour surgery. That you clamp the circulation. It's huge, right? So not everyone can tolerate it, but we make a best guess based on the evidence, whatever evidence exists, but then also like that consensus decision. So it's not easy decisions, and we try to make as objective a decision as possible, but even there, I think, it would be helpful to have even more objectivity. And I think that, because you were asking from one program to the other, even between physicians, there can be disagreements. Exactly. There are lots of disagreements that happen in those meetings. We have like, different people's experiences. Maybe the surgeon had a complication a few weeks ago, and now he thinks, he has his own opinion about like his own risk-taking, behavior as compared to someone else. And then from one program to another, like Toronto, we do transplant pretty complex people. But at Mayo Clinic or other institutions in the US, they may not be willing to take that much risk because of the insurance plan system and all of this. So public health care versus private care, there may be differences in the behavior of programs or physicians as well. So I think there's so many like complexities to any decision we make in healthcare that are influenced by environmental circumstances, personal experience, and behavior.
Thank you. Yes, sir.
Thank you for the talks. So one of the things that I was personally very glad that I'm observing more in the MLHC talks was that, like, also discussing like population health, public health aspect of things, and one of the areas to grow that was touched on by Dr. Rosella's presentation was about like how much we wouldn't see like work on the prevention side of things. So I mean, there was another talk that like there was an example that like, for example, if you create a health AI tool and deploy it in a hospital, right? So you would see like downstream so many other things would be touched. And in that sense, I would also even argue that like if you create something on the prevention side, I mean, I would, for example, offer an example that I have worked a little bit on obesity, right? If you touch it, it's going to touch so many other things down the road. And I think with the whole craziness about anti-obesity medication these days, people are seeing some of those, right? Now, my specific question is that, like, I mean, that issue exists. What do you see as some solutions? Like, I mean, how we can... Do you think this has to do things with the long-term effect of things, like not really objectively being able to see like down in the mortality or like a cost? And like, what do you suggest, like as a community, can be done to grow those type of efforts in that area?
Yeah. I mean, I think the reality is that the state of our healthcare systems now, most funders of healthcare and governments are realizing they have to pay attention to prevention. We have not invested in it. You know, we spend 1% of our healthcare budget in prevention. It's ridiculous. That's why we're in the situation that we're in, right? So my first answer to you is there needs to be better incentives to fund the type of machine learning work that actually is targeted towards prevention. And that those kind of incentives, I think, will really spur a lot of activity. And we've seen it in our AI for Public Health network, that we now have a bunch of practitioners working exactly on those issues. But what I'm starting to see a lot is people taking it into their own hands. So I worry a little bit it's turning into more of a people out of the healthcare system adopting machine learning enabled tools for prevention, and it's sitting outside the health system. And I think that's where we have to pay attention. If these are actually offering the benefits that we are seeing, and they're going, you know, sometimes they get bucketed in the kind of wellness industry, which I don't like that term, but we got to find a way to bring it in a lot more. And so at the end of the day, it comes to incentives, but because we're struggling so much with the capacity of our health system now, I think many funders and health systems are realizing that we actually need to do it. I mean, a lot of Mamatha's patients actually could benefit a lot from prevention and working upstream, and then that allows, you know, the physicians to focus on those complex cases, right? So it goes with incentives for sure.
That's right. I mean, we see many patients at the end of I mean, all of our patients are kind of end of road.
Yeah.
You know, yeah.
Thank you.
Thank you.
Any more questions? No? It is actually 3:30. So we can end now with the questions. And thank you again for the talk.
Thank you.